Great. Okay, so I'm supposed to cover anthracyclines, topoisomerase inhibitors, and antimicrotubule agents. This is a hell of a lot to cover in an hour, so I'm going to try to go through all the salient features. I will tell you that what struck me when I took the boards was how much of pharmacology was in there. Like it was really scary, and a lot of stuff I was just doing it because I did not know the answers to those things. And when I was attending at the VA, I kind of began to do a lot of board review stuff for the fellows based on just pharmacology. At least 10% of your questions are just pharmacology based. And it was like nobody had done, which is why these lectures then began, because we just complained about it and we put together a whole lecture series. Okay, so the board questions. Some of the format of some of these questions may have changed over the years, but this is the general. So what are the following is true regarding doxorubicin? A, it's an anti-tumor agent bound to an antibiotic calitumycin. Its mechanism of resistance is increased expression of topo-2. Crosses the blood-brain barrier. It's a weak vesicant. Cardiac is due to the formation of cytotoxic oxygen-free radicals, and it causes bluish discoloration of the urine. Anyone have it? Okay. The following is true regarding paclitaxel. Cell cycle specific, it's active in M phase. When use of platinum, it should be given after the platinum agent is infused. Mycolysis is common after weekly dosing of more than 6 cycles. And someone asked me last time what mycolysis was. It's your nails that get all dark and black, and in African American patients, you can see their plantar creases get really dark. Hypersensitivity reactions are common in 20 to 40% patients. It's not a radiosensitizing agent. A, C, D, A, B, and C. I'm sorry? F, okay. I'll tell you this in a bit. And then, which of these is false regarding vincristine? It's active in the M phase. It can cause SIADH as a side effect. When used with filgrastim, it decreases the risk of neuropathy. In patients with ALL, it is administered 12 to 24 hours after L-asparaginase, since the latter inhibits clearance of vincristine. None, C and D, B and C. Yeah. Anyone? Okay. All right. Let's talk about this then. You can figure it out. Okay. So here are your anthracyclines, and the answers will come up as we're going through these. So the anthracyclines basically, or they're also called anthracycline antibiotics, daunorubicin or daunomycin, and its liposomal form, which is available. Doxorubicin or adriamycin, idurubicin, epirubicin, which is used a lot in Canada and in France. Valicin, which is really used to treat bladder cancer. I've never used it. And the anthracenediones is mitoxantrone, which we use a lot in, say, MEC, or used to be used a lot for prostate cancer, but refractory prostate cancer. Topoisomerase inhibitors could be topo-1 inhibitors. So those are your TCANs, the irinotecan, topotecan. And your topo-2 inhibitors, etoposide, tenofoside, and even doxorubicin, which is actually a topo-2 inhibitor. And then your antimicrotubule or antimitotic agents are your taxanes, and I'm only going to cover paclitaxel and docetaxel. Vinca alkaloids, vincristine, vinblastine, vinorelbine, and vindesine. I'm only going to cover vincristine because I just cover everything. So the thing that I really wanted to cover was the mechanism of action, the mechanism of resistance, which really bothered me because that was two questions in the boards were mechanism of resistance, and I didn't know any of it. What do you tell the patient when you put these people on these drugs? Like, what do you have them expect when they going through treatment? What is the toxicity? How do you dose reduce? What are the drug interactions that you need to be aware of, which is another favorite board question, and then the FDA-approved indications. I think with any chemotherapy, you need to know a cell cycle because most chemotherapy really is dependent on your cell cycle. Your S phase is basically where DNA synthesis commences. Your DNA basically doubles, so the polymer cell remains the same. And in the M phase, basically the cell actually divides into 2 identical daughter cells, and there's 5 steps of mitosis. And basically your anthracyclines and your topo-1 and 2 inhibitors act during the S phase, inhibit replication of DNA, and then your vinca alkaloids and your taxanes actually work in the M phase of the cell cycle. So anthracyclines basically are derived from the Streptomyces bacteria. The first anthracycline that was developed was daunorubicin. Really, the mechanism of action is simple. It inhibits DNA and RNA synthesis by integrating between base pairs. It actually prevents replication. It inhibits topoisomerase 2 enzymes, so it preventing the relaxation of a supercoiled DNA. So the way I think of topoisomerase is your DNA is basically a nice tight helix, and as replication starts, it starts to loosen up, and that loosening up requires your topoisomerases to help it kind of relax and uncoil so that then replication can happen. So it basically inhibits that enzyme, so it prevents replication. It prevents the loosening of the coils and thus prevents replication. But most importantly, it creates these ion-mediated free oxygen radicals that damage the DNA and cell membrane, which is also a mechanism of its toxicity. So kind of a key factor in its mechanism of action. What are the mechanisms of resistance? One is it decreased expression of the MDR gene with elevated levels of the P-glycoprotein. And I always think of P-glycoprotein as a efflux pump that sits within your cell, and basically you put the drug in. If you have MDR, it expresses for PGP, it'll push all the drug out. If there's decreased expression of topoisomerase 2, if there's a mutation in the topoisomerase 2, there's decreased binding affinity of the drug, and if there's increased expression of sulfhydroproteins. Just FYIs, the anthracyclines do not cross the blood-brain barrier. It is more lipid-soluble. Daunorubicin is more lipid-soluble than doxorubicin. It's a real strong vesicant, and extravasation can lead to tissue necrosis and chemical thrombophlebitis at the injection site, which is why we ask for a central PICC line or at least a Hickman line for our AML patients. And especially in the community, it's important to let you know if patients come in for a IV doxorubicin push, the nurses are really good and they can do it a Profil IV if they have to. But in the community, it's an absolute no-no because most infusion centers don't have skilled nurses like we do have over here. It's typically always given as a rapid IV infusion or an IV push. It's a quick push that the nurses have to give. It's rarely given like Arati is as a continuous IV infusion. It's never given intramuscular, subcutaneous, or intrathecally. It's almost fatal. And alopecia is universal. So when you give people 7 and 3 during their induction chemotherapy, they will lose their hair. It's not the cytarabine that's doing it, it's the daunorubicin that's doing it. And this is true when they come back for their consolidation with HiDAC, you'll see they have that little peach fuzz of hair, but they don't lose their hair then because you're just giving them the Arati. It's the anthracycline that causes the hair loss. And usually it's reversible. Typically we tell young women, your hair will come back 5 to 7 weeks after termination of treatment and will then continue to kind of grow. FYI for patients again, both daunorubicin and doxorubicin cause this red-orange discoloration of your urine. Usually happens 1 to 2 days after giving the drug. Mitoxantrone causes a bluish discoloration of the urine, the skin, saliva, tears. Myelosuppression is universal. It can cause leukopenia, typically 10 to 14 days, with full recovery by day 21. And patients should be cautioned to avoid sun exposure and wear sun protection when they're outside. So based on all this information, the first question that we went through, is it an anti-tumor agent bound to an antibiotic, calicheamycin? Nope, because that's actually Mylotarg. Mylotarg is an anti-CD33 monoclonal antibody. It's bound to calicheamycin. So the drug actually binds to CD33 based on the antibody, then enters the cell, and it's the calicheamycin actually that causes the DNA damage. One mechanism of action is increased expression. No, it's decreased expression. It does not cross the blood-brain barrier. It is a strong vesicant, and E was around cardiotoxicities due to the formation of cytotoxic free radicals. It causes bluish discoloration. No, Dono and Doxo cause reddish discoloration. Mitoxantrone actually that causes a blue discoloration of the urine. I guess the questions that are kind of sexy and people ask about with anthracyclines is which anthracycline do you use in AML induction? There's several articles. As all of you who rounded up on 9100 know that it's really physician dependent. There's lots and lots of data on this, and that could be a lecture in itself. But what I use is that there was just an article in PLOS ONE that compared idarubicin, so 7-3 with the same dose of Arati, but idarubicin versus daunorubicin. And overall, even the Japanese Japanese and some other groups will say that idarubicin is probably better in terms of your CR rates. It's better in terms of your overall survival and event-free survival. It does not decrease your relapse-free survival, though. However, this was a big Japanese study that looked at over 1,000 patients who were young, who got 7 and 3 with either what they labeled high-dose daunorubicin. Yes?
Oh, so was that previous slide Donna for younger patients or Donna?
This is all cycles, all various doses, either 45, 50, 3 days, 5 days. Correct. That's why people criticize it. For example, this Japanese study did 50 mg per meter square for 5 days. That's they labeled as high-dose daunorubicin. Our high dose is 90 mg per meter square for 3 days. So that's 270 milligrams per meter square. This is 250 mg per meter square. Are you comparing different doses? The idarubicin is standard. It's 12 mg per meter square for 3 days. And they combined it with Arati, 100 mg per meter square. They found no difference in your CR rates, no difference in your overall survival or your event-free survival. Okay, so at this point, we could talk to cows come home about daunorubicin and idarubicin, but the truth is we don't have any daunorubicin in the country. I mean, there is this massive shortage of daunorubicin, and so we're going to use idarubicin for AL trials, and we're going to use doxorubicin for ALL clinical trials around the country. That's so this study also, all of you have probably read this now, the daunorubicin trial in AML patients that Lowenberg did. These were older patients, the median age was 67 years. So people either got conventional dose 45 mg per meter square or an escalated to 90 milligrams per meter square. And the CR rates was higher in patients who got the higher dose of the daunorubicin, but no difference in overall survival and event-free survival. And the 30-day mortality and cardiotoxicity was equal with both the low dose, with the standard dose and the high dose. However, when they did post analysis of trial, they looked at the young olds, so patients who were 60 to 65 years. There was a higher CR rate, better event-free survival, better overall survival in this group of patients from 60 to 65 years of age. So you've got to be careful when people start doing post-hoc analysis because they're looking for something to be positive in a clinical trial at that point. So I always tell people if you're going to read the Lowenberg article, read it in conjunction with the article published right after it, which is the Fernandez study that the SWOG and ECOG did. These were in younger patients. The same thing was repeated. It was AML patients who were younger who got 45 or 90 mg per meter square of the daunorubicin. And again, they had higher CR rates with the higher dose of daunorubicin and better overall survival. They then looked at they did multivariate analysis, and what they found was that the patients who had a better CR rate and better survival were actually patients who were under 50 years, but they didn't see this benefit in patients 50 to 60 years. I agree we're comparing two different trials, but it's hard for me to believe that in one clinical trial, the patients from 50 to 60 years had no benefit, and in the trial, patients who were young or old, 60, 65 actually had a benefit. The other thing that was key to this study was it did not benefit patients who had unfavorable cytogenetics or high white counts, who were older, or who had FLT3 mutations or MLL mutations. So really, it didn't benefit. If you think about a high-risk group of patients, those are the high-risk group of patients, and those are the people you're trying to think of. Can you do a higher dose or a double induction? And it wouldn't benefit a high-risk group of patients. The other thing to remember with the anthracyclines is a radiation recall skin reaction. This is true in breast cancer patients. I haven't seen this in a long time since I haven't seen a breast cancer patient in eons. But basically, it's a skin reaction. They get this dryness. I've seen one very severe reaction with blistering and erythema. So basically, if they've had radiation to the mantle zone like years ago, and they have Hodgkin's and now have breast cancer, and then you give them anthracycline, they get this severe reaction to the chest. It can happen months to years after radiation treatment. Typically, the risk is increased when you give the doxorubicin concurrently with the radiation treatment. There's really no relationship between a dose or radiation dose or chemotherapy dose. The key is to kind of keep the skin moisturized, hydrate, drink lots of water, avoid perfume lotions. So the same things that you tell people who are taking Zolota to avoid hand-foot syndrome, to kind of keep their hands really well, nice and moist, and avoid all the good things that they otherwise can on their hands and skin. Cardiotoxicity is a big issue. So there's a couple of papers now that have reviewed this and have, ASCO actually has recommendations on how to follow cardiotoxicity, how to follow for cardio and pulmonary toxicity in patients who have received anthracycline. So acute toxicity is rare. I've really never seen a patient with acute toxicity. Within the first 2 to 3 days of treatment, right away you see, be short of breath and have CHF-like symptoms. They can have pericarditis. You may go to listen to them and hear a rub, transient arrhythmias. It's unlikely permanent. It usually happens and goes away quickly. The subacute is what you see more often. These are the people you'll see up on the AML floor, the older patients, typically anywhere from a few weeks to a year of treatment. May persist or progress even after discontinuation of the anthracycline. These patients typically will have a dilated cardiomyopathy, and these people really, and once this happens, they're not going to end well because they have a low EF, they just not pump well, then they get septic, and you're pushing all these fluids in them, but the heart doesn't know how to compensate for that. You just basically end up burning the candle at both ends. The heart's not functioning, but you're pushing all these fluids in them because they're septic. And unfortunately, these people I've seen, they don't die because of their sepsis. They just die because they cannot compensate for their sepsis well. And it's really unfortunate. It ends up being a really bad death because there's no way to quickly revert the cardiac function, and you end up withdrawing care because it's never going to end. It's just they're not going to get over it, especially the older ones. And the onset is typically years or decades after anthracycline treatment. Again, it's more CHF and dilated cardiomyopathy that you see. These are the two papers. I just put them here if you're interested in pulling the papers up. These are two articles that are in ASCO that are pretty nicely describe toxicity. The risk factors basically are if you're very old or young, if you have a prior history of high blood pressure or pre-existing heart disease, if you've previously had anthracyclines, Herceptin, or prior radiation therapy to the chest, if you're pregnant or contemplating pregnancy, I don't know how that's a risk factor. I've tried to get that, but it's there, and it's in the ASCO paper. I don't know how to define contemplating pregnancy, but nonetheless.
For males if they're worried about somebody else?
I have no idea. That's a good question. Nothing bad happens to men with pregnancy. That's all I'll say. Okay, engaging in extreme competitive athletics. The risk factors, the treatment characteristics are important. So the cumulative dose differs with the drug. So typically with daunorubicin, it's 550 mg per meter square. So if you look at the studies, until you get to 550 mg per meter square of daunorubicin, the risk is like 1% over a period of 5 years. But the moment you get to 560 and up to 1,000 milligrams, the risk goes up to 30%. So it just jumps. At the moment you get up to 550 mg per meter square, the risk goes up very, very high. Now this dose changes if you're giving it to them with radiation to the chest, with cytoxan. If you're giving somebody AC chemotherapy, then the cumulative dose drops to 300 mg per meter square. So it really depends on what else they're getting with the drug. And the longer they survive, the higher the chance of them developing cardiotoxicity is. To monitor these patients, there's absolutely no standard. So should you be doing endocardial biopsies? The issue is that your cardiac function can actually remain relatively normal until a fair amount of damage has occurred. So if you look at the study that has been done to look at this, the way the pathologists quantify the damage is by looking at something called myofibrillar dropout. And that's defined as swelling of the sarcoplasmic reticulum, and basically all these myofibrils are lost, and they grade this from 0 to 3, so 0 being not so bad and 3 being awful. And you really don't see a drop in clinical function until you get to a score of 2.5. So by the time you have a drop in EF, these people have already killed a good portion of their myocardium. So a lot of people are like, why are you putting people through a potentially risk biopsy if you're not actually going to be able to do anything earlier on and quantify how much of damage they have? Should you be doing serial BNP or troponin testing? That hasn't been looked at in long term. So these are just recommendations that have been put out at ASCO but haven't been prospectively looked at. Should you be doing muggers because they're more sensitive? Should you be doing exercise testing because exercise, when you stress people, it will pick for heart disease better? An echo, a stress echo at that point, there's really no guidelines on how you should be following these patients, which is kind of unfortunate. The best thing to do is actually prevent. So, which is on a clinical trial, if you have an EF of less than 45%, you will not get on the clinical trial. Neither will you go to a stem cell transplant if you have an EF of less than 45%. You can reduce the risk, but not completely eliminate if you use it with a cardioprotective drug like dexrazoxane, or if you use a pegylated or a liposomal preparation, or if you change your administration schedule. So there have been studies in breast cancer that have looked at a continuous infusion over 72 hours or 92 hours versus a push, and they've really found no difference in the amount of cardiotoxicity. So you can, and again, it doesn't eliminate, it just decreases the risk. What is Zinacard? Mechanism of action is unknown, but the thought is that it actually is a chelating agent and it interferes with the iron-mediated free radical generation that the anthracyclines can cause. It does not interfere with doxorubicin, at least as far as the PK goes. It can increase myelosuppression, that is an issue. What it allows you to do is to give anthracycline after you've reached the cumulative dose. So don't give it to them when they start cycle 1. Once they get to, say, 550 mg per meter squared for the daunorubicins, then if you add it on, it allows you to give you more anthracycline if you need to. It does not completely eliminate the risk, it just decreases the risk. So that's why that it does, so in the 3 breast cancer studies that looked at dexrazoxane, starting with their first cycle of FAC, patients actually had lower response rate and shorter time to tumor progression than those who did not receive the Zinacard. And that people brought up that you don't need to put this drug on with their first cycle at initiation of chemotherapy with an anthracycline, because it may actually questionably have some anti-tumor activity and whether it's actually causing decreased response rate because of that. So that's why they want you to get to that 6th cycle and then put them on the Zinacard. There's also an oral form of Zinacard available called razoxane, which is basically in a small study that has looked at this, there's been increased risk of second AML with this drug. So it's kind of been pushed away and no one's wanted to touch it. How do you give the dexrazoxane? It's a geometric dosing. So if you're going to give, it's usually a 10:1. If you're going to give 50 mg per meter squared of doxorubicin, you would give 500 mg per meter squared of Zinacard. And if your creatinine clearance is less than 40, which is a question as to whether you should be even giving anthracycline, then you would decrease the dose of it's a 5:1. Again, do not give it at initiation of the doxorubicin. It's typically after you get to the cumulative dose. And it's typically given doxorubicin or the daunorubicin is given after you give the Zinacard. So the way the PK works is that the Zinacard is given first, and 30 minutes after that you give the anthracycline. Unfortunately, no long-term follow-up studies. And it's really sad. I mean, this drug got a lot of press when I was a fellow, and then I've just seen nothing follow-up. There's been no follow-up studies on this to say yes or no. It's not part of the guidelines. People have just kind of forgotten, and it's gone by the wayside. So that. How dose reduced for anthracycline? This is important. The hepatic, if your bilirubin is between 1.5 to 3, then reduced by 50%. If 75%, if the bili is 2.1 to 5, then by 75%, and you completely omit the bilirubin if it's more than 5. The caveat is that do not do any dose reduction if your liver is full of disease. If you have primary hepatic lymphoma or have a liver that's full of leukemia, give them full dose chemotherapy, because that's the only way the bili is going to come down. I've done this with people who come with a bili of 13, and you scan them and they have just disease in their liver, then you give them full dose like CHOP. I've done this with primary hepatic lymphoma when I used to do all heme malignancies. Give them full dose chemotherapy, and their disease will just melt away, and then their bili will come down. That's the only caveat, that if you have primary hepatic lymphoma, or you have CLL that's infiltrated the liver, or AML that's in the liver, you would give them full dose. For renal toxicity, again, if your creatinine is more than 3, then you reduce the dose by 50% for the daunorubicin. Drug interactions, if you're doing AC chemotherapy, again with cyclophosphamide, the risk of hemorrhagic cystitis goes up if you're giving it with an anthracycline, and everyone knows the trastuzumab or the Herceptin interaction. The risk of toxicity just with Herceptin is 13%, but if you do Herceptin with an anthracycline, it's as high as 27%, so a third of your patients can have cardiotoxicity, so it's important to let patients know and be kind of vigilant for that. These are the FDA-approved indications for anthracyclines, really the ones that I'm about are the first two, which is AML and ALL. But I mean, it's a very ubiquitous drug. I mean, we use it in non-Hodgkin's lymphoma and in breast cancer, and it's one of those drugs that's combined with a lot of drugs that's used a lot. So you really should know how to know about the drug enough to give patients the right information. Okay, moving on to topoisomerase inhibitors. Like I said, the topoisomerases have one single function. It basically solves the problem caused by tension generated in the winding and unwinding of the DNA. So as the helix unwinds, the topoisomerase 1 basically cuts one strand of DNA. So 1 is for one strand and 2 is for two strands, and that's how it kind of relaxes the DNA helix. Inhibitors are topotecan and irinotecan. These are semi-synthetic derivatives of camptothecin, and the way it works is that it binds to and stabilizes topoisomerase 1, and leads to double-stranded DNA breaks and cellular death. For it to be active, you need ongoing DNA synthesis. So it will only act in cells that are actively dividing, which is kind of a mess because then it's acting. Think about all the cells that are actively dividing in your body, your hair and your skin and your mouth and your gut, which is why irinotecan does a lot of the diet, because your gut is constantly dividing its cells and there's ongoing DNA synthesis in there. Irinotecan, or CPT11, is really inactive in its parent form. It's converted to SN38. This is a board question, and I trust you. This is why, but every year the board this is there. Topo2 inhibitors basically are etoposide and tenofovir. They are from the mandrake plant. They are cell cycle specific and active in the late S and G2 phase, and they basically inhibit topoisomerase 2. The mechanisms of resistance, again, if there's decreased expression of topo 1 or topo 2, there's a mutation in the enzyme. If there's increased MDR expression, so the system is pretty constant for these drugs, right? It's either depression of the enzyme, a mutation, or MDR. If you see MDR and PGP, pick that. That's always a good choice for resistance because that is, that will always do it. And then CT11, if there's decreased formation of the SN38, which is the active metabolite of the drug, because of the decreased activity of the carboxylesterase enzyme, then that can cause resistance. Some important FYs, the bioavailability of the oral capsules is only 50%, okay? And there's a lot more nausea and vomiting if you give it orally. We used to do etoposide for, really old AML patients just as a homeopathic treatment, or end-stage lung cancer patients in the VA, we would do oral etoposide. I haven't done it in a long time, but it causes a horrendous amount of nausea and vomiting. If a patient is on warfarin, you have to monitor the PT and INR very carefully. It is formulated in polysorbate 80, so you can see anaphylaxis, and you need to keep an eye out for that. And the thing with etoposide, whether it's PO or IV, the one constant thing that patients will tell you is that they get this metallic taste in their mouth when they get the infusion, and that metallic taste actually persists. The thing patients will tell you is when they eat with silverware, it really is a nasty taste in the mouth, so switching to plastic silverware actually helps, and actually they like the food's better when they eat the plastic silverware. Myelosuppression is universal, and again, the nadir occurs 10 to 14 days after therapy with recovery by day 21. I do want to point this out. Secondary AML with both of these drugs that I'm talking about is important. So with alkylating agents, so cyclophosphamide, melphalan, you see kind of a long latency period. You'll see patients who have breast cancer 5 to 10 years later, you'll see their counts dwindling down. So they'll see this prior MDS-like picture or a pre-leukemic phase. And typically, chromosomes 5 and 7 are affected in these patients. The topo2 inhibitors, the patients who've gotten etoposide, so young men who've had testicular cancer with BEP chemotherapy, or small cell lung cancer, people die anyways, but they live to see AML, unfortunately. But people had doxorubicin, and then this is a much quicker. So this is a latent period that's less than 5 years, and they have no prior MDS or pre-leukemia. So they come into clinic that have normal counts. One fine day you check their CBC, and it's like, boom, they're pancytopenic, and you know that the AML is set in. It's really quick transition, and typically affect your 11q23. And this, I remember, was a board question for me in medicine boards, I remember. This was so long ago, golly. Those reductions, hepatic is if your bili is 1.5 to 3, or your SGOT and SGPT, SGOT is 60 to 180, you decrease by 50%. You do not give etoposide if the bili is more than 3, okay? Redosing, again, no dose reduction if your clearance is more than 50, reduced by 25% if your clearance is 10 to 50, and by 50% if your clearance is less than 10. Important, irinotecan toxicity, the active metabolite is SN38, and the half-life of SN38 is much longer. It's 14 hours compared to the parent drug, CPT-11, which is 8 hours. It's antigenic. It's a moderate vesicant. Be careful when you give it to people over 65 years of age in patients with colon cancer. I remember when the first big colon cancer trial that looked at something else other than 5-FU leucovorin was 5-FU leucovorin and irinotecan CPT-11, which was called the SALT regimen. Came out in 1999-2000. I was a first-year fellow then, and we saw it had a 5% mortality. A 5% mortality in colon cancer stage 4, just for therapy. It was horrible. I mean, people basically died from dehydration and the creatinine going up and doing just horrible because of this drug. So be very careful when you give this drug to them, and you really have to check weekly CBCs on them. UGT1A1 genotype is important because it is located on chromosome 2. This is the gene that's responsible for bears and chronazar. So if you have a patient who comes in and has a bili of, they don't have liver mets, but they have a bili of 1.6, 2, you need to be sure. This testing is sent outside. I think it's part of the guidelines now for testing that you have to test for this, because what happens is that if you do have this genotype, and if you're homozygous for it, with 7 to 10% of the population in North America, it's not an uncommon gene patient to have. You have a horrendous amount of diarrhea, 70% increased risk of diarrhea, 40% risk of neutropenia. So these people don't start at the full dose of irinotecan. They should start at a much like a 50% dose reduction. This was the first drug really that reductions were made based on a genotype, not based on creatinine, or this is true. This is when people say, maybe in 20 years, people will know all the SNPs that people have. You have a little chip that you wear, and you go to Target, and they'll scan you, and they'll say, okay, you shouldn't get XYZ drug because it interacts with this and this and this. This is kind of the first drug that people were able to show, that having a certain type really predicts for toxicity with chemotherapy. Irinotecan-induced diarrhea is really interesting. So what you tell your patients is two things. One is they can have an early diarrhea. These are the people, when you get your doses at the VA, have you ever noticed that you actually write for atropine, right, for your CPT-11? That's for this. This is the early, they have this horrible abdominal cramping when they get the infusion, and that's a cholinergic effect. It actually just causes a horrible amount of cramping. But you give them atropine in case, and that fixes it all because it's an anticholinergic drug. The diarrhea is what really gets the patient. This is what starts 24 hours after the chemotherapy because of direct irritation of the GI mucosa by the SN38. And typically, if you put someone on CPT-11 and don't give them a script for Imodium, then or some antidiarrheal agent, you're just missing the whole thing. Give a big prescription at the VA for the lopamide because they'll start having diarrhea. And if they don't start taking the lopamide right when they get the diarrhea, it just goes on and on and on. So it's not a good idea to have. The way you dose reduce it is, you can find this on the Camtasar, the drug, what's that? Thank you. It's on the that if you pull it up. Basically, if they have severe neutropenia or they have bad diarrhea, so they have 4 to 6 stools per day, then you decrease, you wait, you stop the treatment until the diarrhea resolves, and then you go down by one dose level. And one dose level basically is 30 mg per meter square. So if you give them 90 mg per meter square and as the initial dose, drop it to 16 mg per meter square, and then just keep going down based on this. And this thing that you should just kind of, I would just have it on my desktop at the VA, so I would just pull it up each time, just in case I needed a patient to drop the dose. Again, do not use CPT-11 if the bilirubin is more than 2, because you really don't know if they have the UGT1, and it's really hard to test for it, so they just don't recommend using it. Reductions with renal, there's no dose reductions for your creatinine, but if a patient is on dialysis, which is rare, you don't give them CPT-11. And it has a bunch of drug interactions that I put up over here. The approved indications, so etoposide is given as first-line therapy in combination with a platinum for extensive small cell lung cancer, for testicular cancer as part of BEP, and then TCAN is first-line therapy for metastatic colorectal cancer in combination with 5-FU and leucovorin. So the 5-FU, leucovorin plus CPT-11 or the SALT regimen is what they do for colon cancer, which of course is mute now because we have 50 other really wonderful agents for cancer. And topotecan, I haven't used in a long, long time, but it's basically approved for second-line therapy for extensive stage small lung cancer. So if they fail etoposide plus platinum, then you can give them topotecan. Finally, your antimicrotubule agents, which act in the M phase, your taxanes and your zinc alkaloids. So taxanes, Taxol or Taxol was derived from the Pacific yew tree, and docetaxel or Taxotere was derived from the European yew tree. The interesting thing about your paclitaxel is that it was actually developed in the RDU by Arati and a very nice Indian man whose name is Mansukh Wani, and just my story was that this past 2 weekends ago was Bali, which is the Indian kind of festival. It's like Christmas for us, and I'd gone to dinner somewhere, and this little man sat next to me, and he was chatting with me. He said, "Oh, you're an oncologist at Duke," and he was having this full conversation. He kept talking about Taxol. I was like, "Why is he asking all these questions on how much Taxol I use?" Tell me, Mansukh Wani, and I was like, "This is amazing." He was just this down-to-earth, sweet man, and I was just blown away by him. Such a, like 87 and sharp. Like I was blown away by the man, but I was thrilled to meet him. So, needless to say, I was gloating all over him, but he's just fabulous. Okay, so it is a cell cycle specific agent. It works in the M phase of the cell cycle, and basically it binds the microtubules, prevents, enhances tubulin polymerization. And why are microtubules important? Because microtubules really are part of the spindle apparatus. They are essential for maintaining your cell shape. They are essential for cellular motility and attachment and intracellular transport. So if you basically mess up that spindle, there's a lot of things that can go wrong with that cell. So that's how your act. And I make a big deal about kind of the way drugs act, but really I think in oncology you need to know how your drug acts. Because if you don't know how your drug is acting, you're not going to be able to explain anything to the patient, whether it's toxicity, whether it's when to do a bone marrow biopsy, when to do a biopsy. You need to know how your drug acts for the tumor. Yes, ultimately all drugs will cause apoptosis, but how you get there is really kind of, you need to know that. And over the years, I think people just don't pay attention to how a drug acts, but I think knowing where it works and why it does what it does is basic. Again, mechanism of resistance is easy. MDR1, like I said, always pick that. And if you have alterations in tubulin, that can cause decreased affinity of the drug. Taxanes are important because it is extensively metabolized by your cytochrome P450 system. You can see a lot of third spacing. Pleural effusions, leg edema in patients. Docetaxel is formulated in polysorbate 80, so it's less allergenic than paclitaxel, which is formulated in Cremofor. Both radiosensitizers. Alopecia is universal, and neutropenia is dose limiting with NAVE at 7 to 10 days. Hyperreaction with Taxol is seen in about 20 to 40% patients, so you can have anything from a skin rash, flushing, erythema. Severe reactions could be hypotension, bronchospasm, typically within the first 2 to 3 minutes of the infusion. And it's not because of the drug, it's because of that polysorbate that it's in, the Cremofor that it's formulated in. Looked at the incidence of hypersensitivity reaction when you do a 3 or a 24 infusion, it's the same. So typically you always, when you write for your Taxol chemotherapy, you write for Decadron, you write for some dihydramine, some Zantac, or cimetidine before the infusion. If they have a massive reaction when you give them the Taxol, you have a choice, but you have to give them Taxol again, then treat them with some Solubedrol and 25 mg for the next cycle, and really kind of wait there for the first 2 to 3 minutes when the nurses are giving it them. I've had one patient that I've had to do this for, but you can typically re-challenge them with really close monitoring. Side effects, the big ones are neurotoxicity. So the neuropathy is horrible, especially for older patients. It's a dose-dependent effect. So the more cycles go on, their neuropathy gets worse and worse. So when they come in, you need to ask them, the defining thing is not, if you have tingling and numbness, that's okay. But if you cannot do your ADL, so you cannot button your shorts, you can't hold a pen, you can't hold your utensils, those, if it affects your ADL, then you really need to consider dose reducing them. If they have, especially patients who have diabetes and they have diabetic neuropathy, those are the patients who are at more risk. It is more frequent with longer infusions and at doses of more than 175 mg per meter square. The other effect is that it can cause transient asymptomatic bradycardia in 30% of patients. And then mycolysis is seen patients who receive more than 6 cycles on the weekly schedule. You don't see it as much with the Q3 week schedule. You see it more with the weekly schedule. And typically you see this kind of, the nails get really dark and they get the darkening of their palmar creases. The flu is interesting. So and it's more with Taxotere than you see with Taxol. Typically, people will come in with weight gain, peripheral edema. I've seen pleural effusions. I remember when I was a fellow, the first clinical trials in metastatic breast cancer with Taxotere were going on, and women would come in with these massive pleural effusions, and we'd tap them, and there'd be these bloody effusions, and we didn't know if it was the drug that was doing it, or if it was just that they were failing and progressing, because they had no malignant cells in these effusions, but 40% of effusions can have cells. And we would take them off the clinical trial because we didn't know that Taxotere caused such horrible fluid retention. So really, this is why you pre-medicate patients. So in breast cancer patients, you do the 8 mg PO BID for 3 days. And then in prostate cancer, I think they do the 8 milligrams Q12 hours and 3 hours and 1 hour before the chemotherapy. So you need to pre-medicate with dexamethasone to prevent the fluid retention, because you can see it in 50% of patients. It's not an uncommon side effect at all. Dose reduction, again, for Taxotere, if your billy is over 1.5, you cannot give it. For Taxol, if you have a billy of 1.5 to 3, there's no rule recommendation for dose reduction, but if your billy is more than 5, then you need to stop just the billy a little bit, the whole Taxol. There's no dose reductions for renal parameters. This is something that I didn't know when I was a fellow, and when this question came up, I was like, I don't know the answer to this. This is one of those questions where I just picked an answer because I really didn't know what the issue was. But when you give your platinum agent or when you give your Taxotere, is important in relationship to what you're giving with it. So because platinum compounds and cyclophosphamide inhibits the clearance of Taxol, you give Taxol first and then the platinum. That's sort of Taxol decreases the plasma clearance of doxorubicin. So if you give the Adria first and then the Taxol. If you do it the other way around, the Adria just accumulates in the patient, and that can cause more toxicity. And the whole idea is to decrease myelosuppression. So this is for some reason, I love these questions. And so basically, if you give it with a platinum agent, you give Taxol first, but if you give it with adriamycin, you give the Adria first. The approved indications for Taxol and Taxotere, I'm not going to belabor this. And finally, your vinca alkaloids, your vincristine. It's basically that pretty periwinkle plant that everyone loves to plant around their boxes. It's cell cycle specific activity in the M phase. Again, it inhibits your tubulin polymerization, prevents microtubule assembly, and causes cell death by arresting cell division. It also some inhibits DNA, RNA, and protein synthesis. Again, a mechanism of resistance is if they have the increased expression of MDR, or if they have mutations in alpha and beta tubulin proteins with decreased affinity to the vincristine. Your FYIs for vincristine, the dose is usually capped to a maximum of 2 mg. So as you've noticed with your CHOP or whatever else you use it for, the dose is 2 mg. Whether they weigh 50 to 70 kilos, it's a full dose. And the idea is to avoid neuropathy and constipation in the elderly patient. It is a moderate vesicant, so again, you typically don't give it through a peripheral, you give it through IV. In patients with ALL, the vincristine should be given before the L-asparaginase if you're giving them around the same time, because the L-asparaginase inhibits clearance of vincristine. So if you do it after, the vincristine just hangs around. They have horrible neuropathy and horrible constipation. Never give it intrathecally. It's 100% fatal. Clearly, they've done this in mouse models and found that these poor mice died. And a rare side effect actually is SIADH. It can cause your sodium to go down, and it's because of the SIADH that vincristine can cause. Dose reductions for all vincristine, vinblastine, and vinorelbine. There's no dose reduction if your BIDI is less than 1.5. It's 50% dose reduction if your BIDI is 1.5 to 3, and you completely omit if it's more than 3. There's no renal dose reductions. Your indications for vinorelbine. Navalbine is used a lot in older patients with non-small cell lung cancer with stage 3B or stage 4 lung cancer. And they like it because it's been looked at in 2 studies. One is a mild study, the other one's the ELVIS study, where they've shown that single-agent navalbine is just as good as combination therapy, so it's a good drug to give in older patients with non-small cell lung cancer. Finally, one word about Markibo, which I don't think will ever see the light of day because of all the new drugs that are coming out in AL. So this is liposomal vincristine. There's been 2 phase 1/2 clinical trials. We are actually a center for the phase 3 clinical trial, but we haven't been able to accrue a patient for the past year. And really, there's no dose cap. So this is actually a mg per meter square dosing, unlike vincristine, which is a cap. It's like 2 milligrams for everybody. This is actually a 2.25 mg per meter square dosing for all patients. The reason I say it's not going to actually do anything, because one, it's a liposomal drug, so there's more toxicity. It's longer acting, so it sits around for a long time and causes more neutropenia. The second issue is that none of the studies have actually borne out the neuropathy. So if they can show that the neuropathy actually is less, then maybe people will buy the drug, but they haven't been able to show that it's any better than vincristine. And the third issue is that it's a fussy preparation. So pharmacy requires this broth to prepare the drug in, and that's a really cumbersome way of making the drug. So pharmacies cannot. We can do it over here, but a lot of peripheral people cannot do it. So unless it costs a lot less, or it causes less neuropathy, I don't know how this drug is going to get FDA approved. So we're part of the phase 3 trial right now over here, but I really don't think it's going to see light of day. Those are the drugs. Any questions? I did my job there. It's a lot of information.